Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on the topic of lung cancer, today we're going to be talking about other cancers that can present in the lung but are not necessarily of lung parenchymal origin. Carcinoid tumor and pulmonary lymphoma. So neoplastic carcinoid cells originate from neuroendocrine cells in the bronchial walls. Carcinoid tumor can either present as a pulmonary nodule that's within the pulmonary parenchyma, that's usually in up to about 20% of cases, or it may present as an endobronchial lesion that's within the main bronchi or the segmental bronchi, a more central location. And because of its location, it can cause obstructive atelectasis. When the endobronchial tumor blocks the bronchus completely, the affected lung segment or lobe may collapse. Now, carcinoid may be typical, that's the low grade, or it may also be atypical, which is a more aggressive variant. The typical carcinoids that don't have nodal or distant metastasis will have excellent prognosis. So in a 5-year period, about 92% of these patients would still survive. The atypical ones, the more aggressive ones, tend to arise more peripherally and they have worse prognosis, again, because they are more aggressive. Then there's another entity we call diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, DIPNEC, and it's an uncommon syndrome, and it's characterized by multiple foci of neuroendocrine hyperplasia or tumorlets less than 5 millimeters in size, in addition to bronchiolitis obliterans and multiple carcinoid tumors. Now, the radiologic presentation shows multiple pulmonary nodules with mosaic attenuation of the lungs, and the mosaic attenuation is secondary to air trapping from airflow obstruction. So the areas of air trapping would show as abnormally hypodense areas on the contrast enhanced CT, and then the relatively dense areas or ground glass areas are rather the normal lung. So in this image, we see a rounded right middle lobe pulmonary nodule. You can see how very closely related it is to the segmental bronchus, and there are multiple other tiny pulmonary nodules scattered throughout both lungs, like one here, there's a tiny one here, another one here. And we can also see clearly the mosaic attenuation. So we can see areas of abnormally low density interspersed with areas that appear to be of ground glass attenuation. Actually, the areas that look like ground glass are the normal lung parenchyma, and the areas of low attenuation are the areas of air trapping. And this was a case of diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Now, under pulmonary lymphomas, they can either be primary pulmonary lymphomas or secondary pulmonary lymphomas. Primary pulmonary lymphoma meaning that the lymphoid tissue are originating directly from the pulmonary parenchyma. And secondary means it's secondary to other lymphomatoid conditions like Hodgkin's or non-Hodgkin's lymphoma, which have now extended into the lungs. Primary pulmonary lymphomas are rare, and they are most commonly mucosa-associated lymphoid tissue lymphomas, so multomas. And the most common presentation is a mass-like consolidation limited to the lung parenchyma, but you will not see any other nodal involvement in the mediastinum or elsewhere. That proves it's primarily of pulmonary parenchymal origin. You may also have pleural-based masses, peribronchial or perivascular thickening, and interstitial infiltrates. Then secondary pulmonary lymphoma is relatively more common than primary pulmonary lymphoma, and it includes manifestations of both Hodgkin's and non-Hodgkin's lymphoma. The CT imaging features include lymphangitis, nodular or consolidative pattern. With Hodgkin's disease, you would see parenchymal involvement with lymphadenopathy as contiguous spread of the disease, and it may also cavitate. Now, there's another entity here that we would call post-transplant lymphoproliferative disorder, PTLD. And this presents as a new pulmonary nodule in a patient after a solid organ transplantation. So in this case, lymphadenopathy is also usually present. So in this first image, it's an axial CT zoomed into the right lung, and it demonstrates a region of dense consolidation involving the right upper and lower lobes with air bronchograms. And this was a case of primary pulmonary lymphoma. In this second image, it demonstrates a new nodule in the right lower lobe in a patient 7 months following bilateral lung transplantation. Now, this nodule was biopsied with pathology of post-transplant lymphoproliferative disorder. This diagnosis could have only been made on biopsy. Of course, with the clinical history, we may suggest it. Thank you very much for your attention, and as usual, I hope this has been helpful. The next topic would be radiologic presentation of lung cancer. This is just trying to put everything we have discussed into perspective. And if you are enjoying this, give it a like, give it a thumbs up, subscribe, comment, share with someone you think would appreciate it. And I will see you in the next one.